Much, Chris. Thanks for that introduction. I'm delighted to be invited to talk here today about laparoscopic ventral mesh rectopexy. Just a quick show of hands. Have you all seen this operation? Yep, so that's about half. What about other pelvic floor operations? Delorme's procedure? Yeah, a bit more common. Altmaier's? Yeah, great. Okay, so just to sort of put it in context, this is not really a talk on how to do the operation. It's a bit more of an overview about why we do it, what the indications are, and I can sort of touch on the recent controversies. So I started off as a general surgical trainee in North East Thames region. You were in North West Thames. Colorectal surgery was my area of interest, and I was very fortunate in year 4 or 5 to work for a surgeon who didn't do any other laparoscopy apart from this one operation, because he'd been to Strasbourg and had gone through the training program at the time when the STAR procedure was really popular. So that really set me on the path to getting an interest in pelvic floor surgery. And actually the year of gynae that I did was more oncologically to be able to perform a hysterectomy as part of pelvic surgery. So actually I was fortuitous and lucky to get this sort of year training, which I know can be very difficult as a trainee, to really sort of focus on these more specialised operations. So just a slide to talk about the scale of the problem. So there's a 7% lifetime risk of getting rectal prolapse, and here's a little picture on the side to show what actually happens in the pelvis. It can affect up to 40% of postmenopausal women. That's not rectal prolapse as such, that's pelvic organ prolapse. And as we know from pelvic floor papers over the years, that actually one woman's prolapse can cause very different symptoms to another woman. So actually the symptoms don't always correlate with what you see on the images that you might request. But what we can see here is basically the anterior and middle compartment with the uterus descending externally. And when it does, it brings with it the anterior wall of the rectum. Okay, so this is the pathology. It's more common to get prolapse in the anterior pelvis than in the rectum. It's much more prevalent to attend a gynecological outpatients clinic with symptoms of a bulge or urinary incontinence or some degree of prolapse. Prolapse can mean different things to different patients, but I think that the workload for gynecologists is much more than it is for us in colorectal surgery. What we do know, however, is that when patients have had a hysterectomy for a variety of reasons, that the removal of the lateral supports in the middle of the pelvis can put that woman at increased risk of developing pelvic organ prolapse in future. And if you can see from the diagram, the descent of the uterus means that the dragging down of the anterior wall of the rectum means that some level of bowel dysfunction is unavoidable. So 9% of adults have fecal incontinence, and that encompasses everyone, men and women, for a variety of different causes, and we know that this steadily increases with age. For obstructive defecation syndrome, I think what we're really talking about is difficulty evacuating, constipation. It's a really difficult diagnosis to make, and we can touch on that a bit later, but that is much more common than fecal incontinence. I don't know if any of you are aware about the UK Biobank, but it's a really fascinating observational study that is run by the Wellcome Institute in this country, where the population between 40 and 69, about 5 years ago, were invited on a voluntary basis to give lots of information about themselves, answer a multitude of lifestyle questions, past medical history, habits, eating, all sorts of things, including blood tests and saliva. And I've done a small study that's, a paper's been submitted just on the ladies to see what percentage have already undergone a hysterectomy, and bearing in mind that this is quite a young cohort, so 40 to 69, and what we have demonstrated is that 25% of the population by that time have already had their hysterectomy, okay? So they may not have gone through the menopause yet, so we know that a quarter of adult women potentially are going to run into difficulty if they live till they're 90. So what do? Someone comes to your clinic, and I think it's probably a universal experience that they usually come through the 2-week wait pathway. With all the recent changes in the NICE recommendations, I think any GI disturbance will trigger a 2-week wait referral. And so really the first thing you need to do is make sure they haven't got a bowel cancer, because if you go straight down the pelvic floor route, then you might miss something, for example, a rectosigmoid tumour that could be driving a prolapse or a sort of disturbance of bowel function. And I have witnessed a couple of cases over 20 years where a bowel cancer was detected during a laparoscopy, which raised issues with consent and what to do and what would be the right operation. So the first thing you need to do is look at the bowel and make sure that they don't have a bowel cancer, and that could be a colonoscopy, could be a virtual colonoscopy, could be a flexible sigmoidoscopy, all the things that you would normally do in your units. Once you've got through that, I think the majority of patients would then get a letter saying, you're fine, you haven't got cancer, discharge, okay? And then a small group get trickled back into the system, and that's when they would attend a pelvic floor clinic. I think it's nice to have a dedicated pelvic floor clinic with a bit more time, because I think 20 minutes is not really good enough to really fully understand the patient's perspective. You might need to get a box of tissues out. You might need help from a nurse specialist to support the process, and definitely recommend having a next of kin. So that can be quite a lengthy process, and that then leads you to what to do next. Now in our hospital we do defecating proctogram. We have 2 radiologists who are dedicated to this. There are lots of units that do things differently. For example, MRI scan is gaining popularity, and I think there can be a sort of difference in opinion about whether lying down in an MRI scanner can truly report the gravity of the prolapse, because in the lying down position you may get an under-reporting of the prolapse. The same thing is true of a proctogram. Up to 10% are meant to under-report the prolapse, so really it should be a combination of an examination, which you can either do in clinic, sat on a chair or commode, or under general anaesthetic. Other tests that are useful, endoanal ultrasound to look at the integrity of the sphincter. Now, anal rectum manometry here I think is very important. It's not just a diagnostic test, it's part of conservative treatment. And I think if you have a good unit that provides this, it can be a real gatekeeper. Patients can go to this service, they can have an assessment of their ability to evacuate, and they could potentially go down biofeedback therapy, which means that they could come back to the unit. And for patients who have got a hypersensitive rectum, usually women with irritable bowel syndrome, you could gently inflate a balloon to try and improve the capacity and reduce the symptoms. So this is a sort of overlap between diagnostic and therapeutic. Now, the problem with examination under anaesthetic is the way that I tend to do it is using a CAD, an anal dilator, and Rampley's to see how much the rectum prolapses out through the anal sphincter. I think for any patients, you could pull the rectum down a certain way. So that's very subjective. You could possibly convince yourself of anything. I think it might be better to get a commode in clinic if you have time to see if you can look at the prolapse. And the other thing I tend to ask patients is, can you get a photograph of it? Because really, if you're going to embark on surgery, which at the moment is under a lot of scrutiny, I think you've really got to be convinced about what you're fixing and just how bad the problem is. So, what are the risk factors? Okay, well, we've talked about age, and the significance for women is the menopause. It can happen around 50 to 55. It can be earlier than that, a group of patients with premature menopause. Menopause reduces the estrogen in the tissues and things start to sag. Okay, so the pelvic floor muscles run from the pubic symphysis to the coccyx, and they're strap muscles, and through there you have the urethra, the vagina, and the anal sphincter. Now they split to allow the passage of the baby's head, okay? And to what degree they come back to the midline is different for every single woman. So it is a risk factor, and in all the evidence that I've looked at, usually 2 vaginal deliveries is enough to cause a disturbance within your pelvic floor. Obesity, and here's a picture here. I think we're all aware that we're an increasingly obese population. In fact, the men are tipping the scales, but it's the same trajectory. Things seem to be fairly equal up to the age of 25, and then there looks to be an increase up to the age of 70, where things start to tail off a bit. So I think obesity is a big issue, and central obesity, which is more common in ladies, can really have a negative impact on any surgery you might embark on. Parity, we've talked about increasing age. previous prolapse surgery. And I think actually it's not just a hysterectomy or a posterior vaginal repair. I think any pelvic surgery, we've heard some very nice talks this morning on the anal sphincter. One operation for an anal fistula with a cutting seat on may well catapult you into this category. So I think hemorrhoidal surgery, anal sphincter surgery, any type of surgery which a patient might not necessarily recall because it might have been some time ago. The patients who are hypermobile with a connective tissue disorders, there's a small amount, but they are disproportionately represented in the pelvic floor group because they have a general abnormality of their tissues that predispose them to a general weakening in that area. Now this group here, strainers, these tend to be patients who've had a lifetime of constipation, who have got into bad toileting habits, and essentially have put such a lot of pressure on their pelvic floor that the rectum starts to telescope out. And in that group, I've also seen some weightlifters. And like horse riders, weightlifters are very difficult to engage on using a different type of exercise for fitness because actually the ones who then get rectal prolapse tend to be at quite an elite level. So what are the surgical options? I think it's important to get a feel for who's doing what worldwide, and the most popular operation is a resection rectopexy in America. So this is similar to an anterior resection. What we know, if any of you have looked in a laparoscope of anyone with external rectal prolapse, you'll see a really long widening of the pelvis, a very, very big pouch of Douglas, and the rectum is going out, and it's a very wide expansile area, tends to be with an elongated sigmoid colon. So in America, you would undergo an anterior resection of sorts. In Europe, we favour a sort of fixing procedure. Now that could be a pexy, which could be anterior, posterior. We could use mesh. We might not use mesh. We might put stitches in. We might do something in a perineal fashion, okay? And there is a large group of surgeons in Europe that feel that you must not enter the abdomen because this is a perineal procedure. This is a perineal condition. And those perineal procedures could be a plication, like a Delorme's procedure, which most of you have seen, or an Altmaiers, which is essentially an amputation of the rectum. There are risks and benefits with all of them, and really none of them are ideal. So I'd like to draw you to this landmark paper. It was produced in 1994 by my old consultant, Richard Novell. He is a very influential surgeon. I think he's now retired. He did work in Luton and Dunstable, where I was his SHO, and he then moved to the Royal Free Hospital. And he produced this landmark paper that was described in the British Journal of Surgery. And this to put in context of what we were doing about 20 years ago. This looks at the Ivolon sponge. Have any of you heard of the Ivolon sponge? Okay, so we have been putting foreign bodies, bits of stitches, sponges, it looks a bit like a bath sponge, into the pelvis for years, okay? And where it goes is in the posterior position, okay? Now you could do it in a post-anal approach, or you could do it laparoscopically, or even as an open procedure as they did in those days. The purpose of it was to go down to the back of the sacrum, put the sponge, fix it onto the sacrum, and then fix it onto the back of the rectum here. Now, you'll all know that the back of the rectum has the mesorectum, which is a fatty structure, and in it has the superior rectal arteries. It primarily fixes the back of the rectum in the hope that things will keep up there. Now, in those days, 14 days in hospital, that was your average length of stay. And the real problem with this, and the real reason why we don't really like doing resection rectopexies or anything more major, is because by dissecting the lateral ligaments, you may get intractable post-operative constipation. So here, 50% of patients. Recurrence didn't seem to be much of a problem for the sponge, but the complication rate, and if you talk to anyone that did this sort of operation 20 years ago, what they used to say is it would just get infected and you'd have to take it out. And then that redo surgery to remove it is then very unpleasant in the context of infection. So his proposal was to move from the sponge to stitches, okay, non-absorbable stitches in exactly the same place. So he did this randomized controlled trial, and it was exactly the same length of stay. But what he found was that we had a significant reduction in the constipation, okay? Complication rate looked to be less. I don't think that was actually statistically significant, but it looked to be really promising. So there was much excitement, and this paper changed practice. People dumped the sponge, and off we went with posterior suture rectopexy. And that's what was done for quite a long time. And really the problems with that operation is that really fixing the back wall of the rectum was really not really enough to prevent the recurrence. The follow-up was 2 years for this study, and I think once we got beyond the 2 years stage, there was a very high recurrence rate. And that's where we were until Professor Dorr from Leuven came along, and I can see that he is due to be giving a visiting professorial lecture here in a couple of weeks' time, which I'll be attending. He really changed the face of rectal prolapse surgery. It was around 2006. He engineered laparoscopic ventral mesh rectopexy in order to overcome these issues with dissecting the lateral ligaments. And he also did multiple cadaveric studies, animal studies, just to see exactly what the point of prolapse was. And all his sophisticated research, he was able to confirm that it is the anterior rectum that comes down with the posterior vaginal wall that really is the point at which rectal prolapse starts to become an issue. So he spent a very long time engineering a mesh repair that would leave the lateral ligaments intact, that would have low morbidity, and would arrange for tension just in the right area of the rectum to prevent it coming back again. The operation describes a mesh in the front wall of the rectum and also additional sutures to the posterior vaginal wall, because he believed that 40% of patients with external rectal prolapse also had an enterocele, which is a weakness in the back of the vaginal wall where the small bowel comes and descends down. And the early data looked really encouraging. So the complication rate was less than 5%. Over 2 years, the recurrence rate was about 5%. He then went on to produce 10-year data that showed that the recurrence rate, the mesh erosion rate was the same, but the recurrence rate went from about 4 to 5% to 8%. And this is where we're at the moment. So this is the 10-year follow-up from Leuven, which shows that the recurrence rate is about 8.2% and the mesh erosion rate looked to be safe. Now, because of the anxieties of the mesh, and we'll come on to that in a minute, there have been some interest in biological meshes, and here's one over the side. It's a permacol mesh. And there have been some small studies that have come out from groups in Sheffield to look at the outcomes when you use that mesh as opposed to that mesh. And really what they found is quite impressive. On a much smaller group, they found that the mesh erosion rate is less than 1%. However, the problem with the biological mesh is you may get a systemic inflammatory response. And I think if any of you have put these type of mesh in the abdominal wall, you'll see that patients experience a seroma. If you have to go back for surgery, that they have dissolved into a bit of tissue paper. They don't seem to have much strength. But it might be something that patients find more acceptable because it's not designed to be a permanent implant. Vaginal mesh erosions. So I don't think anyone could have missed the scandal that is going on at the moment about vaginal mesh erosions. Currently, there are 80,000 women who have come together for class action against Johnson & Johnson for the non-absorbable permanent vaginal tape mesh. Now, this is exactly the same mesh, but it is put in through the front wall of the vagina to treat urinary incontinence and prolapse. And really, what's happened is that there is a worldwide worry that a high volume of these patients might need revisional surgery or they might need the mesh out. And just to put it in context, what we know from the gynecologists is that if the mesh is put in an abdominal fashion, the erosion rate is still less than 5%. It's the transvaginal tape that has really caused a massive furore. The data has shown quite nicely that actually it's up to about 2 years where you're most likely to get the mesh erosion. However, there are patients that come at 5, 6, 7 years. So there is currently a lot of anxiety about the fact that the FDA has declared this device as dangerous. So patients are worried, what might happen to me? What might happen if I leave this? Am I going to suddenly develop chronic pain? Am I suddenly going to get a mesh erosion? There's a lot of uncertainty. But the latest information has shown that about 3% of all of the vaginal mesh group may need revisional surgery. So what about our mesh? It looks exactly the same. It's a bit bigger. It's put in abdominally as opposed to perineally. Well, what I would say is that there are far less of us doing this type of surgery when you compare it to the vaginal mesh surgery. The National Pelvic Floor Society has made great strides in undergoing an accreditation process so that surgeons who do this operation are fully trained, so that all the procedures go onto a registry. There's enhanced consent, so in the last month the Pelvic Floor Society have released their own consent form which quotes a 5% risk of mesh erosion and a 20% chance that the operation simply won't work. There's lots of anxiety about, are we going to see the same thing? So we've done possibly 5,000 of these procedures in the UK. Are we going to see a significant number of them coming back with problems? And that is the nervousness, particularly in the colorectal community, when a high volume unit may only do 10 to 15 a year. So in response to the issues that have arisen, NICE have issued some guidance on internal rectal prolapse, because I think what really happened when this operation came about in 2006 is that colorectal surgeons saw the brilliant results and maybe were using it in a wide variety of patients. So obstructive defecation syndrome, so internal rectal prolapse, is this going to really help the symptoms? And actually the latest guidelines say really it has to be focused on external rectal prolapse, and particularly those who have failed conservative measures. And this is a picture of a mesh erosion. So this is the back wall of the vagina. And this is what you will see. It's quite easy to feel. The patients tend to present with vaginal bleeding, and so will usually rock up in a vaginal clinic, a gynae clinic. This one's quite extreme. It's about 2.5 centimetres in length, and you can see that it's quite old because the edges have healed. There's no obvious active infection. But the significance to the woman for this is chronic pain, discharge, no love life anymore, and this patient might be young. This might have a significant impact on her quality of life, and there's no easy way of getting that out. So in the crisis that we've had in Bristol, we've had a lot of patients coming to clinic wanting to know if they can have it removed. They've heard what's going on in the press, they're really worried. And really what we have to be very clear is that it was designed to be permanent. It was never meant to be a temporary operation. The meshes that have been removed, we send them all to pathology and microbiology, and we can see, and we know from the vaginal meshes, that nerves tend to ingrow in the mesh. I think the same is true of mesh anywhere else in the body, for example, the groin. And that may contribute to pain, but we don't really know. There's a lot of unknowns, but there are a group of patients who describe severe pain in the lower sacrum and perineal immediately after waking from the rectopexy. And it could be easy to explain why this is. The protaps we use to secure the mesh in the sacrum, and also the multiple stitches in the perineal body, could explain why some patients have this severe pain. But there's no data to support whether we remove that if it's actually going to improve their pain. But what we do know is that we have to consent them for the whole lot. So they have to be consented for a bowel resection. That would be a low anterior section. There's a high risk of a permanent colostomy. You might even need an ileal conduit if there's been some erosion into the bladder. And there's no guarantee that those symptoms will go at the end of it. So, should we be worried? It's hard to not be worried when we know what we know about vaginal meshes. I think we can reassure patients that they're unlikely, beyond 2 years, they're unlikely to suddenly develop these problems. It's only a real small group that get a problem at 3 to 5 years. And actually, the erosion that I've shown you in the vagina, if you were to see that, you would not really be able to remove that vaginally. There's a high risk of making a rectovaginal fistula, making the scenario even worse for the patient. In gynecology, they do lots of smaller procedures, like they tend to oversew the mesh or use topical estrogen. That seems to work very well in the vagina. The rectum isn't so forgiving. The bacteria that goes into that space drives the infection and can go up to the intervertebral discs. So I think in my experience, it's not possible to get away with a smaller procedure. even this week, Sling the Mesh is a Twitter campaign which has galvanised and grouped together the entire mesh community, and they have done their own research and they have surveyed the entire group, 7,000 patients of all mesh patients, and they found of all the rectopexy patients, 7% have a problem, and it's usually within the first 6 months. So where are we at the moment? Well, it's fair to say that there's lots of nervousness. There are units that don't offer it, that are looking for options. Southampton, for example, now don't go straight for a mesh rectopexy. They will recommend a posterior suture rectopexy, and accepting that 30% will recur, and then they would only offer a mesh if it was a second-line operation. There's lots of surgeons who don't want to go back to the old days, so what would be the option for the patient? Patients don't want the mesh. The options are a perineal procedure which has reasonable results. It's difficult for the younger patient. Conservative options, getting the most out of your anal sphincter, trying to avoid straining. There are things you can do, but genuinely when the rectum has telescoped out, you're in a scenario that is not socially acceptable. And I can't help but show you a video. Now, I did mention earlier that really you should only use this operation for external rectal prolapse, and that actually the stitches in the vagina are probably a bit of overkill. I'm going to show you a video here now of a lady in her 50s, perimenopausal. It's just a before and after shot. And so as you can see here, she's got posterior vaginal wall prolapse. My arm's in the way, so you can't quite see. And here you can see the rectal prolapse, very patulous anus, hemorrhoidal component. There's really a very deficient perineal body. So there is about 1.5 centimetres in the middle, but the whole thing is bulging out. So that's middle and posterior compartment. Oh no, where's it gone? Where's it gone? Let's try that again. Okay, and then after the operation, there. So you can see that that patulous anus has totally been endured. The posterior vagina looks fantastic, and really you can work on that pelvic floor now. You can send this lady to pelvic floor, intensive pelvic floor exercises, and get an improvement in her symptoms. And actually, even though we're not meant to be doing it for middle compartment prolapse, it can have very good results. So, I've now turned into a mesh removal surgeon, and this is my team. And so here we have a urologist, we have a gynecologist, and 2 clinical scientists. Thank you.
Thank you very much, Catherine. Brilliant. Right. Any questions about all that? I'm sure there must be.
Is there something being done upstream of the problem, like avoid these in the first place and for the next generation, for example, C-sections or something?
Well, yeah, that's a hotly debated topic, and there's a big drive from the Royal College of Midwives to try and reduce the number of elective caesarean sections. I think what we don't have is proper support for pelvic floor physiotherapy for patients who have a 3rd or 4th degree tear. They don't always even get an endoanal ultrasound scan. I think there is a big area. The group that we don't get to are the strainers. They tend to be women with a high overlap with anxiety, too scared to use public toilets, constantly deferring the need to open their bowels, and what happens is the rectum and the colon distends, and really it's that group of patients we need to target. Sphincter.
The sphincter.
Yeah, because the obstetricians and midwives are fantastic at suturing the sphincter now. We rarely see problems with the sphincter. That's on the decline. It's the straining population, 20%. Excuse me.
So what's your feeling on non-permeable biological meshes like Stratus, or the non-biological absorbable like Gore and...
Yeah, I offer it. but I do say you're more likely to need some other surgery at some point. And in my experience, they don't tend to like that. In the initial furore last summer, when there was a massive anxiety about rectopexy mesh in Bristol, patients turned away from it. They didn't want anything. And now they're coming back. We've gone through conservative measures and things have got worse, as can happen with time. So I offer it, and I would say less than 10% of patients go for that option because they don't like the idea of needing revision or surgery.
What do you think the recurrence rate is with an absorbable mesh? Just give us
We
some
don't
kind
know.
of idea. Yeah.
We
Is
don't.
there
We've got
any
3-year
early
data.
Yeah.
There's a theory that there's enough scarring in the dissected area that might be enough to hold the prolapse.
I guess that these patients have connective tissue problems to start off with, so their scar tissue is not necessarily very robust.
It might not even scar, yeah.
And you talked about connective tissue disorders. Do you screen at all for connective tissue disorders in these patients?
No, but I'm very careful to avoid a resection in that group because I think it's not going to heal properly.
But a mesh rectopexy you would advise that in someone that has Danos or something of that nature. Do you find you have success with those patients who have underlying problems?
No, my heart sinks. I give them all the options. We do nothing. We do conservative, and then we do rectopexy, be it sutures, be it biological. I've got information leaflets on everything, and I put the onus on the patient to decide.
I had one with Bears Danos, and I ended up doing a rectopexy posterior and ventral, open, and then defunctioned her.
Yes. Yeah.
And she's quite happy with her stoma 3 years later. But I'm hoping that it'll have welded in place by the time I reverse her stoma.
Yeah.
Any other questions?
Would your preference be, if you're going to do something, do it with a mesh then? Is that what you think the best outcomes are?
I'm still putting in mesh, in the right patient. And after the initial hiatus last year of 6 months of nobody wanting it at all, we're now back to, I do about 15 to 20 a year. That hasn't changed over the last 6 years.
That was an absolutely fantastic talk. It just makes so much sense. Just a quick question. I'm Ellie, I'm a biofeedback nurse specialist. Do your clinical scientists actually do the biofeedback?
Yeah.
I thought so when you alluded to the anorectal manometry and the balloon
So we were
distension.
on the capacity trial, we got the high definition kit, and because we got the high definition kit,
You're
we're now
still
able to
using
offer 6 appointments. We recruited 5 patients to that study, and the results looked to be quite good. And I don't genuinely know whether it was the fact that they're being followed up once a month for 6 months, or whether they like the interaction with the scientists, or whether it was actually the biofeedback. But that it is all being analysed, but we did see quite impressive results.
I think in terms of the straining as well, that's absolutely essential, where they're just going to strain it back out. Getting them on board with the new, visual biofeedback like the one we used in capacity is going to show to be really effective.
Yeah.
Brilliant. Absolutely brilliant.
With regards to, so obviously that video that you showed us, it's quite a marked prolapse.
Yeah.
Is it so the kind of patients that aren't likely to benefit, is that the ones who have a very small degree of prolapse but very significant symptoms in terms of, say, constipation, or are those the ones that you would tend not to
No, it's more
operate
the
on?
anatomical abnormality, because the symptoms are unique to the individual. And that's very true of vaginal prolapse. A massive external vaginal prolapse may bother some women and not others. So I think in terms of the actual symptoms, all we can say is we can fix anatomically the rectum, but we have to be very specific about the fact that they may never properly evacuate again, and that they may get pain on intercourse that might affect their marital or any kind of relationship. So we have to be completely honest about the fact that it is an anatomical operation that may not necessarily help.
I remember going to a conference a couple of years ago on this subject, and the gynecologists were talking about sutures and the importance of sutures rather than just the mesh itself. Do you have any thoughts on what type of suture we should be using?
Yes, so there was a shift about 6 years ago when I first became a consultant from Ethibond on the mesh to PDS. And the reason why we all trained on Ethibond is that it's much easier to do a laparoscopic knot intracorporeally. I don't know if any of you have tried to do this, low down in the rectum with the light lead upside down. It's technically very challenging, which is why there's a huge potential for robotics in pelvic floor surgery. You're a very long way down. For ladies, elder ladies, they tend to be quite slim, so you do have space, but it is technically very challenging. And I think Andre Dor's operation says you must put a minimum of 8 stitches in. So really, it's a lot. And I think really we were very upset about Ethibond. It was thought to be the reason why you developed a mesh erosion. I have had a mesh erosion and there is still ethibond coming out. The shift to PDS, although it is more demanding surgically, and I think for you guys as trainees, trying to get that training is really difficult, because if you do it once every 6 weeks, you go straight back to square one. You know, it needs to be continuous, a continuous apprenticeship, which is why a dedicated time in pelvic floor, you know, would be advisable. Since the stitches have changed, I think we've also stopped putting them in the vagina as well. So I think it's a multifactorial.
You know, from the discussion and all, we know that there are a lot of concern about that non-observable mesh. If you really want to use a mesh there, you always prefer to use biological mesh or any type of
No, I
observable?
rarely use it. I rarely use it.
So which one you prefer, and what is the reason?
It's Tylene mesh, and my colleague Tony Dixon did a lot of work in rectopexy types of mesh. There was a paper published between Bristol and Oxford about 3 or 4 years ago looking at the mesh erosion rates with the various different types of mesh. There was one mesh that was popular around 2007 and 8, which was a polyester mesh, and that one was thought to be linked to a higher mesh erosion rate. The titanium-coated Prolene mesh, which is what we use now, has got a much lower mesh erosion rate, and the data is more robust. So I think it's useful to give the patient a choice if we're going to go down the mesh route, but I still stick to the titanium-coated Prolene mesh. And I do try and reassure patients that we use it elsewhere in the body and have done for years. For example, groin hernias use Prolene mesh. It's exactly the same thing. It's just the current anxieties, which haven't yet been borne out, but will it? It might be. Who knows?
Great, thank you very much. Brilliant. Thank you very much, Catherine. So next up we have Alyssa Bradshaw, who I worked with very happily for a couple of years here at St Mark's. She is a specialist nurse in biofeedback and a real expert who's got years and years of experience in this field.
Good Lord, what have you done?
Yeah, it was automatic shutdown last time.
Not this
So
time.
we've given her a stinker of a topic to talk about perineal
An
pain
absolute
syndromes.
rotter of a top. You'll have to help me
I
with
will
the...
help you. I will help you. Yeah.
Thank you.
There we go.
Where am I now?
You're down here. Off you go. Thank you very much, Alyssa.
No pressure. Actually, I'm Ellie Bradshaw. Only my mother and Chris Thorne call me Alyssa. I'm actually the lead nurse now in biofeedback, so things have evolved since you left us, Chris. But I'm now the lead nurse of a team of 8 specialists of the pelvic floor. I've got quite a tricky topic here. I'm going to be talking about the management of perineal pain syndromes. So what I did in preparation for this talk is I actually went back and looked at the earliest of the literature where these patients are first described, and I think this quote really sums up some of our feelings about these perineal pain syndrome patients. So when discussing the perineal pain patient, the ideal case for doctors dealing with acute medical and surgical patients is a clearly defined disease that is easily amenable to treatment. This truly depressing patient has no recognisable disease and little prospect of treatment. I sincerely hope we've moved forward in terms of how we view these patients, but we have all, I think, been in a colorectal clinic where we've been faced by these very refractory, sort of difficult to treat, difficult to diagnose set of symptoms when it comes to pain. So I'm going to be talking about the most common perineal pain syndromes that we're likely to see in a colorectal clinic or a pelvic floor clinic. I'm going to be talking a bit about the current theory on causes of this and the current treatment options. So you may see perineal pain described as non-organic. Sometimes it's called functional, i.e. a problem with a function, or sometimes dysfunctional pain. You can see either of those terms used. It has to be present for more than 6 months to be classified as perineal pain. And of course, as has been alluded to, you have to exclude all organic causes. So endopelvic or anorectal disease, and you need to use the appropriate radiology, endoscopy and a physical examination. You'll find and you'll know from your experience that these symptoms often exist alongside other chronic pain syndromes. So you'll often see that these patients have IBS, for example, or they have refractory bladder symptoms. So you'll all know these terms, you'll have seen these terms from the start of your training and up to the present, that when you read patients' notes, you will see terms such as levator ani syndrome, proctalgia fugax, myofascial syndrome and coccydynia. Actually, in 2018, this year, the European Association of Urologists looked again at the use of these terms and looked again at the classifications. And what they did was they did a very comprehensive literature review, and they also spoke to the leading experts and examined the current classifications. So basically, the major changes are in terms of the fact that if no obvious cause is found and the pain is poorly localized or generally described as being associated with several organs, then the term chronic pelvic pain syndrome should be used. If the pain is localized to a particular organ, then it's appropriate to use a specific term such as anal pain. So, chronic anal pain syndrome, which was formerly levator ani syndrome, tends to be associated with bowel, bladder and sexual dysfunction. And there's pain post-defecation. So think about this when you're asking your patients and assessing in terms of the history when the pain is most likely to occur. When it comes to intermittent chronic anal pain, formerly known as proctalgia fugax, this tends to be unrelated to defecation, so it is neither precipitated nor exacerbated by bowel emptying. So chronic anal pain syndrome, Rome 3 criteria still stands at the moment, and this is described as chronic or recurrent rectal pain or aching. Episodes last at least 20 minutes, and it, of course, again present for at least 6 months. So to diagnose this, and bear in mind this is just sort of narrowing down your differential diagnosis, it's not going to be an absolute and total confirmed diagnosis. These patients tend to exhibit exquisite pain on traction of the puborectalis, and this is thought to be due to an overactivity of the pelvic floor muscles. Intermittent chronic anal pain, recurrent episodes of pain are localized more to the anus or the lower rectum. Episodes last from several seconds to 30 minutes, and there's no pain in between these sun episodes. They just come on, and it might be described as cramping, stabbing, or aching. So you may find that they have an initial trigger for this, the pain goes, and then during stress in their lives, in terms of emotional stress or sort of stress at home, the pain is re-triggered. So when we're talking about the musculoskeletal pelvic pain syndromes, this was formerly known as myofascial pain syndrome. This is recurrent or episodic. It's associated with negative cognitive, behavioural and emotional consequences, and I know Catherine was talking about that there, the effect that these symptoms can have on a person's whole life. So trigger points may be found in several muscles. So you might find trigger points in the abdomen, you might find them in the thigh or in the paraspinal muscles. We've all seen coccydynia. Pain perceived in the region of the coccyx, sometimes associated with a fall, not always, and it's associated again with very negative behavioural or emotional consequences for the patients. So neuropathic perineal pain is a separate thing. So it's not a nociceptive pain, it is a true neuropathic pain. So you'll see this in pudendal nerve entrapment or inferior cluneal nerve compression. And this is quite interesting. So when you question your patients, you'll find that they often have the worst pain on sitting. So it's postural perineal pain. It's exacerbated by sitting, and they'll often say, I cannot sit on a hard chair. It becomes excruciating. They'll either lean over to one side or they have to get up and move around. It tends to be relieved by sitting on the toilet because obviously they're not sitting directly on the part of the nerve that's bothering them. There doesn't tend to be a sensory deficit in the area, and the pain doesn't wake the patient up at night because they're not sitting on it. So that's something you need to remember in your assessment if you're thinking about a neuropathic perineal pain. So what we tend to see in the colorectal clinic, we tend to see a sudden trigger for the symptoms. So something that's happened, and then following which we start to see these very refractory pain symptoms reported. So infection, surgery or trauma, and it tends to persist beyond the normal healing phase. So we would, of course, expect somebody to have pain following a procedure, but it tends to just sort of drag on. They never feel quite right following a surgical intervention. So there's often a clinical context predisposing to the pain. So 15% of perineal pain patients actually have fibromyalgia, which raises the possibility that this is very connected to visceral hypersensitivity in the same way that we see in fibromyalgia. They also have chronic fatigue and they also have chronic migraine. So common triggers, you'll have seen them: abscess, fissure. Lots and lots and lots of these patients have originally had a fissure, now appears to be healed. However, something has changed in terms of the pain signals. Hemorrhoids, seen a few who've had banding and or hemorrhoidectomy. Obstetric trauma, we talked about that there, not always recognised in terms of what has happened in childbirth. Prolapse, there was a very interesting published article that said that high-grade internal rectal prolapse can cause perineal pain when you're looking at obstructed defecation. And of course, it's not worth forgetting that it could be caused by the prostate. So they might have an enlarged prostate, and this is then causing pain and discomfort in the perineal area. So, diagnosis, again, we're talking about narrowing down a differential diagnosis because these things are very difficult to classify. So you have to take a history, obviously, physical examination, select the specialist investigations, and of course make sure that when you see the patient you have excluded all possibilities of organic diseases. So ask about the overall functions of the organs within the pelvis. So ask about history of surgery, infection or trauma, and this could be historical, it doesn't have to be a recent thing. Anorectal and bowel function. Think in terms of, is there straining? Do they feel empty on the toilet? Do they feel complete of evacuation? Do they feel as if they're bulging in the posterior compartment when they go to empty? Sexual function, urogynecological function as well, of course, in terms of where they are with their hormones, what are their bladder like, what are the bladder symptoms like? Psychosocial aspects, is it precipitated or exacerbated by any stresses at home, for example, and their general physical pain levels. It was suggested in the literature that you actually ask the patient on assessment, how does the pain affect you emotionally in terms of how it would have an impact on other aspects of the life. So physical assessment, always worth reminding patients that you might be about to make their pain worse, particularly if you're looking at things like trigger points. So PR examination, first thing, have they got an enlarged prostate if they're a chap? Obvious one there to look for. When you're assessing the sphincter, think about the tone, think about the muscle movement. Is there a range of movement? Is there any specific trigger points that become apparent? Ask the patient to propel and relax, not easy in the left lateral position, but see whether they have the ability to be able to propel and simultaneously relax. Sometimes you'll see anismus, patients are unable to relax the anal sphincter. Sometimes they cannot propel. They have no propulsive force for whatever reason. Look for a prolapse. Obviously, we totally agree with Catherine there in that we believe a prolapse should be assessed on the toilet. What we do is we take the patient into the toilet, get them to strain, and then we come back in and have a look to see whether or not there is any evidence of external prolapse. If you suspect pudendal palpating the region of the ischial-spinal Alcops canal can reproduce the pain, but you are not necessarily going to get a formal diagnosis from that. You do need to think about sending off to allied specialists for an examination of the spinal, muscular, nervous and urogenital system. Diagnostics, we talked, didn't we, there about MRI, defecating proctogram. Very difficult to push anything out when you're lying on your side in a confined space, when somebody's screaming at you over the sound of the MRI scanner to push it out. Not necessarily the most natural of situations to be in, but it is the most, the best we have in terms of visualizing things dynamically. So it does show the movement in a very real term. So pelvic floor descent, abnormal anorectal angle, rectal interception, rectocele, enterocele and cystocele, as we've said, may be underplay because you are not factoring in gravity. The other thing that I need to add there is performance anxiety. So this actually overdiagnoses anismus because I've had several situations where patients have been sent to me for anismus, I've sat them on the toilet and what they've actually got is a full thickness rectal prolapse. You can't necessarily see it if somebody's very anxious about performing this examination in front of strangers on their side. So, anorectal manometry, can be useful to diagnose dyssynergic defecation and hypersensitivity of the rectum. And a lot of patients with pelvic pain have hypersensitivity. A lot of IBS patients have rectal hypersensitivity. Endoanal ultrasound may identify structural issues that may not have been previously identified, for example, obstetric injuries that have gone undiagnosed, sometimes for a very long time. I've seen cloacal defects that have been missed. Some things can happen like that in a patient's past, and an endoanal ultrasound is a good place to be able to better visualise the structure of the anal sphincter. So, recent pain theory. So, although pain is related quite often or reported to be in one particular organ, the pain might not come from that organ. The pain may actually originate from somewhere else but be expressed and localised to one area. So subtypes of pain are now categorised as relating to nerves, so neuropathic pain, central sensitisation, so this is the visceral hypersensitivity which we see in conditions such as IBS and fibromyalgia, complex regional pain syndrome, and emotional components. So there is a theory that some of these patients actually have a form of PTSD. It tends to be the ones that have had some sort of trauma or abuse, but it seems that these models for looking at perineal pelvic pain can be applied. So, many of the mechanisms for CPPS are based within the central nervous system. The majority are started by some sort of peripheral stimulus, and the patient might not even be aware of what that is. Bear in mind, you may be uncovering abuse from the past, which the patient has not elaborated to. That's why the assessment is so important. So the endocrine system and hormonal release may be affected by early life emotional stress. And this goes on to affect the nociception and pain perception of the individual. Many studies have shown the correlation between perineal pain syndromes and sexual abuse. One study purported that 58% of these patients have had abuse. It's not necessarily sexual abuse, apparently, in terms of the fact that if you're emotionally abused, you can have all sorts of problems in terms of interpreting pain and getting dysregulated pain signals. So, the treatment, the bit you've all been waiting for, it's not easy. I would start with that. The first thing is to educate the patient regarding the condition. So although patients are very geared towards an organ-based approach, it's in my bladder, it's in my anus, it's in the prostate, you have to describe to them, although that pain is expressed by one particular organ, it's not necessarily the cause of the problem. The pain should be described to patients as a local, regional or central dysregulation of pain mechanisms. So treatment often pertains to regaining muscle function. We do improving defecation dynamics using things like rectal balloons to address dyssynergia or obstructed defecation, teaching patients to be able to propel and relax simultaneously, using a rectal balloon, and also in terms of using a rectal balloon for desensitization when it comes to rectal distension. You have to try and improve the range of movement within the pelvic muscles because often these patients are hypertonic. They don't have a full range of movement between the muscles. So in terms of the sphincter, they can't necessarily squeeze and relax appropriately. And biofeedback is quite useful for that in terms of giving them a visual aid to be able to see how they're controlling the muscles. Desensitization, so we do myofascial release in clinic. It's something that we do. We do have some success in terms of that. And we teach the patients to use stretchers and to self-massage trigger points at home. This is a Pelvic wand, one of the instruments that we do suggest that patients buy. And we have had good success with this. I would say you need a multimodal disciplinary approach to this type of thing. So we work with a pelvic floor physiotherapist, a pain specialist, and a bladder physiotherapist as well before we engage in treating these patients. So treatment, general relaxation techniques, psychological support. Sometimes I think just identifying, and acknowledging the pain is so important for these patients. Quite often they've had a pretty torrid time in terms of not really receiving a diagnosis, not necessarily getting the support that they need. Studies have actually shown the positive effect of hypnotherapy and CBT, and that tends to work on the anxiety aspects which drive the pain and exacerbate the pain. Psychotherapy can be suggested where you elicit a history of abuse or trauma. And medication, so they do sometimes use the anticonvulsants. You'll see gabapentin is often used when it comes to neuropathic pain, and also tricyclic antidepressants have been shown to be effective. So, in conclusion, the literature all agrees on one thing, and that's that it's really complicated. I would say that treatment needs to be multimodal and involve allied healthcare professionals. So use your MDT, discuss it with everybody from a pelvic floor perspective. A pelvic floor pain specialist, a physiotherapist, is an extremely good place to start in terms of if they've had experience of treating these syndromes. And psychological support is increasingly recognised as essential. So we're moving away from an organ-based approach and moving more towards looking at the underlying psychology of pain. Thank you. Thank you.
Thanks, Ellie. Sorry for being so formal with your name.
I know.
Now, this is an interesting topic, and it's a bit of a heart sink when these patients turn up in the clinic. So, have you guys got any questions? I've got a question. I think we all want to know what you do with the pelvic wand.
What do you think? What do you think you do with the pelvic wand?
Well, it's something to do with, I think it's a technique for myofascial release, but that's also slightly mysterious, I think, not only to me, but to much of the audience. Can you tell us about that?
It's applied to the trigger points, and it's a bit like dilatation, actually. We teach them to manoeuvre. It's basically internal massage, manoeuvre over the trigger points in order to be able to release the fascia.
And how long do you do that for?
Well, only a minute at a time,
Yeah.
over a period of several weeks, and then we reassess the muscles. And you can often feel them relaxing, actually, believe it or not. I always thought it was a bit of bunkum, but having reassessed these patients, you can feel that the muscles lengthen. You know, so where they have a lot of tension in the muscles will get longer and more supple when you examine them.
You know, all joking aside, where are the muscles that you find are most commonly affected by this? Is there a particular sequence of points that when we examine them, we should be looking for specific points that are commonly affected by?
No. Just use your clock face as you would in terms of anything. It depends on the original painful stimulus, you know, why they've got the pain in the first instance, but they can get referred pain elsewhere, which is quite confusing.
And the other thing about clinical examination, because I think this is very specialist actually, is when you talk about the diagnosis of chronic anal pain syndrome, formerly levator ani, and you're talking about puberectalis identification. Where do you apply traction on puberectalis to try and make that diagnosis? Is that something you do?
No, just a PR examination.
Yeah. So you're feeling anteriorly.
Yeah. Feeling anteriorly and then pulling.
And you put some pressure, and then you ask them to contract against your finger, with your finger placed
and
anteriorly.
It tends to be
tells
quite
you if you've got
obvious. It tends to be quite exquisitely painful for them.
Right, excellent. Well, that's cleared that one up for me.
Thank you for talk. I've got massive respect for you surviving this as your day job. These patients are difficult. How do you go about getting the psychological support you need on the NHS?
I have to say we're
with that? So you're doing it yourself?
We're hugely lucky here because we actually have, within our biofeedback team, we have a specialist counsellor, and we also have a psychiatrist who's based here. But in terms of generally, it's extremely difficult. What I would suggest you do is ally yourself locally with somebody with an interest and try and get them into your MDT, because that tends to be the way in which we've been able to get past the CCGs in terms of them not necessarily wanting to fund things. If you can ally yourself and get somebody that wants to attend your MDT, pelvic floor MDT, or you have functional bowel MDT, you tend to be able to obtain funding. It's really difficult. I think the major problem is not just the talking and the listening, you know, which they appreciate. It's when you unearth something really horrendous, and there may still be a safeguarding issue. So you have to be prepared that if you're going to open that can of worms, you need to know where to go for support with it. So try and find a local specialist that's keen, would be my advice.
Thank you very much for your speech. So I'm very interested about the topic. I know perineal pain is very complicated. I also do some the therapy in my country. I come from China, so sometimes we can't find any reason for the pelvic pain. So we'll do the PNS for these patients. So what we'll do about if you can't find the reason, what we'll do for the patients? Thank you.
Sorry, what will I do for? Sorry.
So I know that there's a lot of reasons for the
Yes.
pelvic pain, but sometimes we can't find.
Oh, if you
after
can't find the
examination.
cause.
Yeah, it's very difficult. So what we'll do if you can't find the reason for the pain, so we'll choose the PNS, some the pelvic, the nervous stimulate.
Mm-hmm.
So we'll choose that.
Well, there
Sometimes
is
in
some
China, we'll do the acupuncture in
you
the
do acupuncture,
pelvic.
yeah. So there actually is some evidence for neuromodulation. So
Yeah.
we did a small trial, didn't we, Greg, in SNS for anal pain. Yeah. Greg's still traumatised. I think it worked for a couple of patients. I mean, it remains to be seen. We did PTNS in anal fissure, and that seemed to show some positive effects. I think the take-home message is that first, do no harm. Don't jump in doing anything surgical until you're pretty sure it is the absolute, last option, until you've tried everything else.
Great, thank you very much indeed.
That's all right, absolute pleasure.
Successfully running about half an hour behind time, so we may have to rethink our rethink our roundtable discussion. No, there isn't. I think you're there. So this is Greg Thomas, who was appointed at Ashford St Peters in Surrey last year and was hand-picked by Carolyn Vasey as the man to give this talk when I found she was not going to be available. So thank you very much indeed, Greg.
Okay, thanks, Chris. So I'm going to talk through, I'll give you an overview of sacral nerve stimulation and tibial nerve stimulation. So these are essentially electrical stimulation treatments, primarily used for fecal incontinence. There are some other indications, but the main use is for fecal incontinence, and that's what the basis of the talk will be about. Fecal incontinence, as Catherine's mentioned, is reasonably common. It's probably significantly underreported. People don't come out with this. They'll talk about leaky bladders. They won't talk about leaky bowels and defecatory problems as openly. You can classify it as urge, passive. So urge, they've got to rush to the loo. Passive, it'll leak out without really being aware of it till it's out. Or mixed, we have features of both. There's often overlap with constipation as well. Lots of causes. I've highlighted the three groups that SNS typically applies to. So incontinent sphincter mechanisms, trauma, whether it's obstetric, iatrogenic, accidental, and then of coming more significance is those with reduced rectal capacities, those who've had an anterior section or radiotherapy, and that's getting a bit more attention at the moment. Certain patient groups will come through the door with this. Typically female, though not always, usually often majority of postmenopausal. There may be a significant obstetric history, maybe some anal surgery, an anterior section, radiotherapy, diabetic, obesity is a risk factor. And there's certain subgroups. Males will often have passive seepage, and young females with a very recent obstetric injury who'll present early on, but they can often soldier on for quite some time. So in terms of a treatment pathway, I've sort of put one up here. So patient presents with fecal incontinence. As we've said, it's disturbance in bowel habits, so you need to look for a cancer or a colitis or something further upstream. Once you've done that, then I suggest you look for an external rectal prolapse first, because that should be corrected straight away. You won't improve anyone's incontinence with that. If they've got, and you can investigate them, if they've got a full thickness external sphincter defect in selected patients, you might want to go straight for a sphincter repair at that point. But generally, patients are fed down towards the biofeedback section, okay? So nurse-led conservative multimodal therapy is early here. That's probably a good definition for it. If they fail to improve with that, we then offer them neuromodulation, so SNS and PTNS at that point. Further down the line, neosphincters aren't really applicable at the moment. May consider a bulking agent, and then a colostomy is probably at the end of the road for many of these patients. So sacral nerve stimulation itself was first reported in the early 80s for bladder dysfunction by some Californian surgeons, and then picked up by Klaus Matzel in Germany for fecal incontinence, I think in about 95 or 94. There was some enthusiasm in constipation, but it's not been proved to be particularly effective, so I'm not going to dwell on that too much. So SNS is essentially chronic continuous electrical stimulation of the third sacral nerve root through a lead that's placed via the sacral foramen. Okay, so directly over the tailbone, you pass a lead, and I'll go through that in a second. You have a test stage called peripheral nerve evaluation, which the patient must satisfy to then be given chronic stimulation. Okay, so they have a temporary test period for 2 or 3 weeks. So it's 94. The original paper from Matzel reported on 3 patients. At 6 months, 2 had achieved full continence and 1 showed improvement. And he also looked at anal squeeze pressures and felt they were increased. So the test stage, P&E, is a day case procedure under local or even general anaesthetic. If it's under local, the wire's placed in and you're looking for sensory stimulation around the anus or the perineum. If it's under general, you can crank the voltage up and you're looking for a contraction of the anal sphincter, bellows contraction. The patient's sent away with an external stimulator, that was now a small white box, but the brown box in the lower picture, for 2 weeks, and they keep a bowel diary, and you compare that to how they were before. And if there's a greater than 50% improvement in symptoms, then the wire comes out and you offer them permanent stimulation, which is shown here, which is a more advanced lead in the top right. You've got the little plastic barbs which anchor the lead into the bone of the sacrum, and the electrodes are passing through and sitting on the other side, and they should be up against the 3rd sacral nerve root, or the 4th sacral nerve root in some cases. Local or general, this is connected to a pacemaker implantable device. Under the skin, it's switched on, and that normally lasts for about 5 or 6 years before the battery runs out, and you can get lead failure in some patients. So we mentioned this for incontinence, so it works urge, I think probably better for those with urge incontinence, probably a bit less so for those with passive leakage. It will work with those with a sphincter defect. There's some evidence it works in those who've had their rectum removed or partially removed or hit with radiotherapy. And there's even a few papers looking at its effect in patients with pouch dysfunction. Not really effective for constipation, but if you look at some of the papers, those with rectal hypersensitivity may get some benefit from that, but you won't get funding for it in the NHS anymore. How does it work? There's been quite a lot done on this. It's a busy picture. That's just a summary of all the studies that looked at anal manometry, so anal squeeze and resting pressures before and after SNS. The upshot was there wasn't a significant change in motor function after sacral nerve stimulation. So although you put the lead in, you see a contraction, what this isn't doing in the longer term is tightening up the muscles, okay? That contraction's a reflex from stimulating ascending sensory pathways. What we think it's probably doing is it's stimulating or modulating ascending sensory pathways up the spine and having an effect that way. But what's it doing? Well, they've looked at its effect in the sensory cortex, and there is activation in certain areas of the sensory cortex in those who undergo SNS, and particularly those who have a good response. Maybe some effect on colonic motility, but the reports are conflicting. Maybe some effect on rectal sensation, but then you've got patients without a rectum who'll benefit. Anal canal sensation more recently, but not peripheral motor. But does it actually work? Well, there's been a couple of studies comparing to placebo. So an early one from Karen Invasi here looked at 2 patients. The device was switched on and then switched off. Double-blinded crossover style study, and significant difference was demonstrated. A larger study from France did the similar thing for 4 weeks in 27 patients, and again demonstrated a significant improvement. There's a large study being undertaken at the moment from the Royal London and the Charlie Knowles' group. Big multi-centre study often looking at a similar thing over a much longer time called the subsonic trial. So those results will be, I suppose, out in a few years' time once recruitment's been completed. How well does it work? Well, there's quite a lot of single series studies showing quite favourable results. So, I mean, if you glance through these, you've got 75% past the test stage with big improvements in incontinent episodes per week at the top, 31 to 4, over a follow-up of a couple of years. 80% success rate there in the next paper. Again, improvements in the Wexner, the Cleveland Clinic Incontinence score. And Wexner's group found a 90% improvement in 90% successful response to test stimulation. You'll see the 50% improvement in symptoms crop up a lot in the literature. It's probably a reasonable significant marker, but it's essentially an arbitrary figure to try and demonstrate clinical significance, okay? Now, so it seems pretty good, but this paper came out a few years ago, which I thought was quite clear. It's quite interesting. It took prospective 50 patients that passed through this process. Now, 74 passed the P&E stage, 26 didn't. Okay, so just follow the numbers down. Of those that had a successful P&E, 27 or 54% from the initial 50 patients had this greater than 50% reduction, and 13 patients were left continent. Now, if you look at those who didn't respond, 74% of these patients that are offered SNS from the start to finish are still incontinent, and 46% will have no clinically significant or 50% improvement, clinically significant benefit at all. So it's perhaps not quite as effective as some of the other studies are made out. How can it be improved? Well, the stimulation settings are all related to much earlier work done in animal models looking at bladder dysfunction. The frequency of 14 hertz, pulse widths of 210 microseconds, and at subsensory voltage. So can these be manipulated? Well, that's been looked at by a couple of the Aarhus and St. Mark's groups. Again, not really. One study doubled the pulse width and halved the pulse width and the frequency likewise, and did a complicated crossover paper. Not really a significant difference. Stimulate at sensory threshold, so where they're feeling the tingling. Generally, you have it running below that level, and reducing it much more doesn't seem to make a difference either. So stimulation parameters don't seem to affect this. Can you put 2 SNSs in? Works a bit, maybe 2 of them will make it even better. That doesn't seem to make a difference either. We tried putting a TENS machine over the lower back. That seemed to work reasonably well in a small group, but it has small numbers, and the results are probably reasonably modest when you look at clinical significance. So there are some problems. There's a high failure rate on intention to treat basis suggests the patient selection is probably flawed. We don't really know how this works. It is expensive. It's I think around £12,500 for the whole thing, and the batteries are about £5,000 to £6,000 to replace them. The leads are about £2,000. There is an infection risk with this, which may necessitate removal of device. American paper quoted 10%, a meta-analysis done earlier thought 3%. And there are a number of patients that will have their devices removed ultimately. So a paper from Yas Maeda looked at 150 patients. 67 of these will experience pain or discomfort at some point. A lack of efficacy or loss of efficacy is reported in 68 and 87 patients. And 31 of these 150 patients had their device removed or turned off at around 3 years because it wasn't working, it was causing them too much trouble. So this will get better when we work out when the mechanism of action is really understood. You can then improve patient selection. And the technology will change as well. At the moment you've had the same device for 15 years, maybe longer. There's a smaller device coming on the market now, which is this thing down there. So I've got a laser pointer at the bottom, the small silver thing, which is very small. It's rechargeable and will last up to 15 years, but I think the cost is reasonably similar. So tibial nerve stimulation, or posterior tibial nerve stimulation, is presumed to work by remote modulation of the sacral plexus by stimulation at the tibial nerve down by the ankle. So inside leg, just behind the medial malleolus, you stimulate at that point. And likewise, it's presumed, although not really investigated or reported, to have a similar mechanism to SNS. And again, the first reports are from the urology world. You can use it with a needle electrode, shown at the bottom, or with an electrode pad, shown at the top. And the stimulation is intermittent here. Patients come into hospital for a series of treatments over a 12-week period, go away, and then when the effect starts to wane, they come back for top-ups. So this is one of the earlier single-group studies looking at how effective this was. This is from the Royal London. We've got a decent number of patients. The passive ones, those are passive leakage. It's a smaller group. They didn't seem to fare particularly well, but those with urge or mixed incontinence did pretty well. You got incontinent episodes dropping from 4 down to 0 and 5 to 1, and the deferral time's improving. Deferral times, urgency is something to always look at with patients with incontinence. If they're patients with extreme urgency may well not leak very much, but that's because they're often housebound. If you're on the loo all the time, you'll never be incontinent. So, although they may not, so always bear that in mind when you're assessing these patients. Transcutaneous stimulation. There's been a few studies. One looked at a prospective trial compared an hour to 4-hour stimulation using a single pad. Again, this showed a drop of 2 contact episodes per week down to 0.5 and 4 to 1. We tried putting pads on both ankles, and this improved things a little bit as well. and 60% got the 50% improvement. So this is much cheaper. The needle stimulation, I think, is about £500 for the box and the needles. The electrode pads are really cheap. You can do this from home. They don't always have to come in. It's intermittent therapy. It does require top-up treatments. Now, there's an acupuncture point down by the ankle, which will do lots of things for you, including bladder problems and also bowel dysfunction as well. And there's also one around S3 as well. So I think that's quite interesting. Now, which is a slight anomaly for pelvic floor literature, there's 2 large randomised control studies looked at a treatment. One from France compared transcutaneous stimulation to sham. This showed no difference in incontinent episodes per week or urgency between sham and electrode pad. Okay? They thought there was some improvement if you looked at a 30% gain, but I think that's probably not of clinical significance. That suggests it doesn't work. Percutaneous or needle stimulation again was matched up to sham by the Confident trial. And again, there's no significant difference between both the sham and active group, and groups achieved around 30% improvement. A prospective study compared tibial nerve stimulation to SNS, and this was a pilot study. It's blinded. Because it's a pilot study, not powered, they didn't perform any comparative analysis. But the authors felt that both PTNS and SNS did provide some clinical benefit, perhaps of a comparative nature. So tibial nerve stimulation, it probably is better than sham or placebo. I think it does have a role. Those who don't want to undergo SNS, for a variety of reasons. Those are maybe more minor and moderate symptoms that haven't quite got back to where they want to be after biofeedback. They're very frail. And also as part of the whole biofeedback conservative treatment pathway as well. So in summary, neuromodulation, so SNS and PTNS, is an important part of patient care for incontinence. If you look back at the older treatments, so things like graciloplasties, sphincteroplasty, which is still performed, but not as common, not as often as it is now, post-anal repairs and those sort of things, certainly SNS isn't probably far off as effective as those older treatments, but it's far less invasive. Again, mechanism of action is the key thing here. Once that's worked out, you can improve patient selection, optimise the technology, and really make this work better. And its use in LARS and post-radiotherapy is, I think, of interest, and this probably needs to be explored a bit more as well. Okay, thank you. I've got some papers there as well, which are worth looking at.
Fantastic, thank you very much. Right, now it's the final session of the morning. Have anyone got any questions about this topic? Slightly mysterious.
Just a quick question about PTNS. How often do they have to wear it for in order to...
So it's not really clear with the electrode pads. I mean, most places will offer needle stimulation. They'll come in and they'll have 20 minutes or half an hour, either once a week or twice a week, and for 12 sessions in total. And that's the typical protocol. They go away and come back if the symptoms get worse. So there seems to be some kind of hangover effect with this. If you assume it works, I think it probably does a bit. Yeah.
Ah, excellent. Thank you.
What sort of numbers of patients are you seeing with this condition? If they've gone through the sort of management of their prolapse and they've gone through the whole biofeedback thing and psychological support, how many are left?
Well, it kind of depends where you... I don't know the numbers nationally that are having sacral nerve stimulation put in. It's certainly been squeezed down to certain centres. It depends on the volume of the centre you're working at. So here there were, I mean, I don't know how many there were planting a year, maybe 40 a year or so, 50. We've got a reasonably busy unit where I am, and we're probably doing about 15 to 20. But these are patients who've been, as you say, been through biofeedback, you know, the whole medical treatment, all sorts of things before they get to that stage. Yeah.
It's a stoma saving operation.
Yeah. So there were things like artificial sphincters. So something called the magnetic anus. Did you heard about this? That's now been taken off the market. That was an option. There used to be inflatable artificial sphincters you could put in, sphincter bulking agents. They're not particularly used anymore. You know, a sphincteroplasty in selected cases is probably beneficial. So those with those with a full-length defect, that's within sort of there to horizontal but no further round, and they've still got some decent function. You can probably get them better by bringing the muscle together, but otherwise probably not worth it.
Sorry, that's really important. So what's your selection criteria for doing a sphincter repair?
So it's full-length defect. They've got some decent functions. They're all in manometers. You need to examine them. If there's no squeeze at all, then it's effectively paralysed muscle. And again, it's, you know, you're looking at, if there's a very small gap, it's not worth it. So say sort of 90 to 180 degrees is probably the gap that's worth bringing together. Yeah.
I'm just slightly confused with the figures. It's probably my
No,
stats knowledge, but in terms of 2 studies showing that it's basically no better than sham, how do you then interpret that to be 30 to 50% probably?
No. So I think PTNS in about 30%, SNS up to about 50 to 60% of those that go through that pathway. So no, I don't think you'll get up to 50% of patients having a significant benefit from PTNS. So it's about a third. And even the sham control studies demonstrated that, although sham got something similar. I mean, I think it's probably got a role. Again, for those with maybe more minor symptoms or those who just don't want SNS. But I don't think this is effective.
I certainly had some very good experiences with it. For the odd patient I've sent along, it's been fantastic, life-changing for them.
SNS or typical?
SNS.
Yeah.
So what are your referral criteria to your unit? What if people are referring regionally to you? What do they have to reach a threshold of a certain score, or? No,
not really. I mean, I think you know, they have to have gone through the whole biofeedback. So whether it's a good pelvic floor physiotherapy or a nurse-led department, they've got to have gone through that and still have. But in terms of actual number of Compton episodes, I mean, I haven't really got a number. I suppose if they're having accidents, again, it comes back to urgency as well. You see, they may not have many accidents, but they may be just sort of toilet hopping because of urgency. So you need to drill down in the history a bit more about that.
I don't think these patients volunteer themselves unless they've got some sort of quality of life issue.
Yeah.
Great. Any other questions? Okay, great. Okay. Well, look, we're going to try and do this round table discussion now. It's a bit of a novel idea. I hope it might work. So we're going to have a 5-minute break, and then we'll sit down. We've got Catherine, as Ellie seems to have disappeared, but we might get her back, and Greg, and we just have 5-10 minutes around the table just to have a discussion about the topics we've mentioned. Okay, so quick cup of coffee, and then we'll sit down at the table, and then it'll be lunchtime.